So hi everyone, I'm the president of MMR SOC. Unfortunately, Dan can't make it today, he's a bit busy, so you won't see our curly haired friend. So we have another lecture, part of our AFP series, and it'll be on critiquing papers, and we're joined by Dr. Harry Spires, who is an ACF in Cambridge. He helped us a lot in Manchester as well. Any questions can be put in the chat and we'll answer them at the end, and just be kind to everyone, please. Thank you.
Brilliant. So yeah, thanks, Fong. So yeah, my name's Harry. I'm one of the academic clinical fellows in HPV and transplant down at Adam Brooks in Cambridge. I did an AFP in Manchester at MRI over the last 2 years, and I've only just come down to Cambridge. So I know that the MMR SOC has done wonders for the students and has built loads up, and they were very, very kind last year, getting me along to do bits and pieces. So my plan is to basically give you a bit of a lecture today. By lecture, I mean kind of informal talk today on how to critically appraise a paper. It's something that you just need to be able to do, whether you do academia or not. It's a useful skill, and some of the interview panels will have critical appraisal stations on there. Apparently this year Manchester doesn't have one. It didn't have one when I did it. There was no critical appraisal station of an abstract. It was just interpreting data. So I don't know how it's changed in the last 2 years, but apparently there's not one for Manchester. I know London 100% does have one. I think Cambridge has one as well for the AFP guys. But basically, yeah, this is an overview for that. So I'm assuming you're all applying for AFP, but if anyone's here who's not applying for AFP, that's absolutely fine. That's not an issue whatsoever. This will be exactly the same otherwise. So I'm going to share my screen, which we've established does work. If you have any questions, best thing to do is stick them in the chat, and I'll try and answer them as I go along at the end. I think, as Fong said, this is being recorded, so it will be available afterwards. The slides are mine, but if you want to steal them, you're more than welcome. Key caveats to this talk. So I am not a statistician, okay? I am not going to be able to teach you everything you want to know about statistics. I am a firm believer that for everything you should do in medicine and academia, you have a system for working through and interpreting, and this is literally no different. So if my screen will let me move forward, yeah. So I've got loads of stuff floating around in the background. So plan today is, yeah, to talk a little bit about evidence-based medicine and the hierarchy of evidence. This is all something you guys will know, and you'll all have your own definitions, but I would highly recommend you have a definition for when you go into your interview, because if someone asks you that most basic question and you can't answer it, it looks a little bit silly. And evidence-based medicine is basically why we do academia. The hierarchy of evidence, you'll all know the pyramids of the multicolours, and we'll go through that quickly. I want you to understand a little bit about different forms of research. Again, I'll come on to that when I get to there. And then, yeah, I've got a system that you will all have your own system, or you should have your own systems. And this is just my one and the kind of widely accepted way of doing things. I'm then going to go through a little few kind of bits of that. So talking a bit about internal and external validity and what they both actually mean. Very, very brief things on statistics. Again, not a statistician, not here to teach you all of stats, but just simple things like p-values. The difference between statistically significant and clinically significant. Now that's something that might sound like there's not much difference at all, but there's actually a huge difference. And yeah, so that's the plan to go through today. All right. So I keep clicking. So what is evidence-based medicine? So the definition that I like to use is it's basically the implementation of research to deliver the best possible care you can for your patients whilst taking into account clinical expertise and patient values. Now that's important because we do all this research and we say, right, we've done a randomized controlled trial of X, Y, Z, and it shows this and this. But actually, particularly now in a kind of modern era, for want of a better phrase, we very much have a shared decision-making process with our patients. And actually, they want to do what's right for them. And just because our clinical trials and our research say one thing is a good thing, it doesn't necessarily mean it's the best thing for them. So shared decision-making is absolutely essential. And the other thing is taking into account your clinical expertise, your kind of own experiences of what you have and haven't seen, what you can and can't deliver. Saying to someone that I'm going to do X, Y, Z, because it's a really fancy new technology might be okay if you're somewhere that practices that technology regularly, but if you don't have that clinical expertise and you can't deliver that, then you have to take that into account when you're delivering your care for your patients. So that's my definition. And I think it basically incorporates everything that evidence-based medicine is. But just make sure you have a definition for when they ask you in your interviews. You've all seen this. This is the kind of hierarchy of evidence going from 5 up to 1. I'm not going to go through every single thing, but you guys should be aware of it. I would recommend that by the time you get to interview, you can just draw it out from memory. It's not actually that difficult. This is quite good. I think it's off the first page of Google. Essentially, you start at your basic science stuff, and then you move up through kind of weaker evidence of case reports and case series. And then as you go through, you have slightly better structured studies that go from retrospective to prospective. And it'd be good for you guys to know the difference between retrospective and prospective and the different pitfalls and advantages of both. And then you have randomized control trials. And once you have enough randomized control trials, ideally someone does a systematic review or a meta-analysis of those trials and gives you an overall arching kind of answer to a clinical question that they've asked. And that's where you get your guidelines from, okay? So learn those essentially. My thing is clicked. I don't know if it's working either way. Yeah, so learn those, all right? In your interview, they're probably... That's what it is, sorry. Siri has joined in the conversation. In your interview, they'll probably give you a randomized trial and ask you to kind of critically appraise the abstract from a trial. They might well give you a systematic review and kind of meta-analysis, and I'll talk a little bit about those a bit later on. So you need to have a system for critical appraisal, okay? So the system that I use is PICO. You've probably all heard of this, and it's very simple. You read the abstract, and from that, you come up with a summary, and this is how you present all of it, okay? So you have the patient demographic. So who are the patients that this study is kind of assessing? What's the intervention that the study has implemented versus the standard? So what's your comparison? What's the kind of gold standard that they're comparing against? And then what are the outcomes? So very simple. So you might have a randomized trial of using haloperidol versus, I don't know, olanzapine for delirium management in geriatric patients over the age of 65. And so your patient cohort is patients over 65 with delirium. Your intervention is the use of haloperidol against your comparison, which might be olanzapine, and then the outcomes would be whatever your outcomes are. So it's very simple. It allows you to read an abstract and then summarize it back to them. And I use that as if someone says to me, tell me about this abstract, that's the first line that I give them. I read it and I give them back a PICO line, and that sets the scene for you. Then you can break it down a little bit. So these are, again, the kind of main bits when you're breaking down an abstract. So have a look at who the authors are. Are the authors world leaders in their field, or are they people you've never heard of who have no real experience and just did it to get a quick publication at med school? We've all been there. Which journal is it published in? Are you reading a randomized controlled trial in the ridiculous journal of surgery from somewhere with an impact factor of 0, or is it something that's been published in the New England Journal or the Lancet, which usually pre-COVID have a very good stringent way of peer reviewing and publishing articles? And then you can just break things down in your simple kind of 4 categories: introduction, methods, results, and conclusion. And there's things you look for within those that we'll talk about as we go through. And then at the end, the final thing to comment on is the external validity of your study. So you've done a nice PICO, you've told them what it's about in a brief sentence, you've been through and kind of picked it apart a bit, told them a bit more about the study. And then the real question is, does this actually apply to me and my practice? How will this change my practice? Or will it change it at all? Or will it do absolutely nothing? And that's the key question. So this idea of validity is very important. And it's basically the validity of something is how true the findings actually are. So if a study is not valid, the findings are not really true, they're not really helpful to anyone involved. But if your study has a good validity, then you can be pretty sure that your findings are important, and not important, that's the wrong word, but they're true, and therefore you can take them at face value, okay? So there are 3 things that affect this that you must think about when you're assessing the validity of something. One is chance, because chance happens in absolutely everything that we do. And there's a chance that your research has happened because it's happened, not because of anything you've done. Bias affects the validity. Okay, we've all heard of bias, and we'll come back to that a little bit later. And then confounders, which are those factors that don't quite fit into bias, but they influence the validity of a study. Okay, so those are the three things that affect the validity of a study, all right? And they are absolutely essential. Bias is the one that you can control the most. Okay, you can do everything in your power to reduce the bias. Okay, if you go onto places like Wikipedia, for example, there's about 12 million different types of bias. Okay, you can basically pick a word and put bias after it, and that's a type of bias. It's that common, but it's the one you have control over. So when you're designing a study or you're designing a trial, designing a piece of research, that's what you need to be preempting and trying to reduce as much as possible. And then confounders are the other thing. So you will know confounders and you'll be able to identify them, and then you will be able to adjust for them in two different ways that we'll come on to. Okay, so those are the two that kind of within your control, bias being more so, but they're in your control. And then you have internal validity and external validity. Now, the internal validity of something is how robust the methodology is. So the setup of the study, how you've gone and run your study, and then how you've analyzed your study, which statistics you've used and why you've used them. And if that's watertight, if you have excellent methodology with well chosen statistical analysis to represent your findings, then the internal validity is very, very high, i.e. the paper has a robust setup, or your study has a robust setup, and then the results should therefore also be of high quality. And as we said, the external validity is how applicable that study is to your patient population or to other people's patient populations. Okay, so internal validity, how well set up is your study, how well have you carried it out? External validity, how applicable is it to other people who are going to be reading your paper? So chance is very simply a random error occurring. Okay, it happens all the time in everyday life, not even research. Okay, but in research we are very fancy and we call it a p-value, and it gets the value alpha. Okay, and it's basically the likelihood that the findings you've got in your study are purely due to chance. Okay, now what that actually means is it's how likely you are to have had a type 1 statistical error. You need to know what a type 1 and what a type 2 statistical error is, okay? So a type 1 statistical error is where you incorrectly reject a true null hypothesis, i.e. there was no difference between intervention. So your null, you might be looking at a study saying drug X is better than drug Y at doing whatever. Your null hypothesis is therefore that the drug makes no difference whatsoever. And a type 1 statistical error is where you incorrectly reject a true null hypothesis. So you find a difference when there isn't a difference at all, okay? Or you find something that isn't actually there and it's purely by chance. And the p-value will tell you the percentage chance, okay? So what percent, or how likely it is due to chance. Now, if you actually do a bit of reading, p-values are not that good a way of assessing chance, but it's the best that we have. And some papers and some journal editors have said that actually, rather than accepting these p-values of less than 0.05 as being statistically significant, that's how we all talk about it, they say actually we should drop it down to less than 0.005 so that you're absolutely watertight, and therefore you can only call something statistically significant when there is almost no chance whatsoever of it happening. But that's not realistic because we can never be that sure about things, really. So you need to know that chance will happen. It's given the value alpha, okay? And it's the chance of you having a type 1 statistical error, okay? So either incorrectly rejecting a true null hypothesis, i.e. finding something that isn't actually there, or when you incorrectly accept your actual hypothesis. So you incorrectly find something that isn't actually there. Bias, we all know a little bit about, okay? So bias is by error not occurring by chance. So bias is an error that you have created. It's a systematic error that comes within the methodology, whether that be from the setup of the study or the analysis. And therefore it will affect the accuracy of the results of your study, okay? It does compromise the internal validity of a study, and that's why it's important to get your methodology right first time around. So therefore, you do everything in your power to reduce bias, okay? So when you're looking through all these abstracts that you're going to be going through as practice, and when you're critically appraising them in your interviews, you want to be looking for any possible sources of bias, okay? Now, a confounder is a different factor to the one that you're studying that will have an impact on the results that you're looking at. So the classic one is smoking and lung cancer and alcohol. We know that if you smoke lots, you get cancer. People who smoke lots tend to drink more. Doesn't necessarily mean that alcohol causes more cancer. However, people who drink more will have higher rates of cancer. So it's a confounder, okay? So there's two ways that you can get rid of it. First, well, the first key thing is you must acknowledge a confounder. You must state, this is a confounder and I'm aware it's here. And then there are two things that you can do. One, you can do some fancy statistics to weight confounders, i.e. to balance out the results and the impact that they have. Or you can try, when you're setting up your study, if you've got two groups of patients, to have equal numbers of co-founders in each group, okay? So those are the two ways you can deal with it. And you can look in your studies to see if people have done that, okay? So those are the three things: chance, bias, confounders. Those are the three things that will affect the validity of your study, all right? Now then, so those are the things to keep in mind as you're going through your article, okay? You've done your PICO introduction, and now you're actually picking apart the study a bit. You've looked at the authors. There's some second-rate authorship by Spears et al. On some awful paper from whoever knows where. Okay, you've not published in a very good journal. So you can actually say that. You can say it's not published in the best impact factor. The authors aren't well known, or they're not kind of leaders in the topic. So it's okay to kind of think about that when you are appraising research. And then the introduction. So is the topic they're publishing on actually anything relevant? Okay, is it something that's important within the field? Sometimes you'll find, not sometimes, sadly a lot of the time you'll find a lot of research that is done because people need PubMed IDs and because people need to get this whole publish or perish thing. And actually you can end up finding articles that aren't really very relevant on issues that aren't actually very relevant at all, okay? So have a look and see, is it something that is relevant, all right? Have the authors made a good case? By which I mean, have they actually set out the scene for why their piece of research is important? Have they given a good review of the literature and basically laid the land for, or kind of shown you what's out there and what's important? And then have they put it all into context? Why is their study important in this context? It's not telling you about their results. It's just saying, this is what we know already from the data, and this is what we think, and actually this is why our study is important in the grand scheme of what's already going on, okay? So that's what you need to be looking at with your introduction. Then you come to your methodology. Now this is where we look immediately for the internal validity, okay? So you're looking at how they've set things up. Are there any areas that bias may have snuck in, okay? So simple things that you'll be looking for. So if you've got randomized controlled trials, you want to look at how patients were randomized, okay? If they were randomized at all. There's a great difference between just saying, oh, you can go in there and you can go in there, versus having a random number generator and assigning patients numbers, versus all sorts of different ways of randomizing, okay? Blinding. So if you've got two different treatment arms, who knows that they're in the treatment arm? Does the patient know which arm they're in? Does the clinician who's treating that patient know which drug they're giving? Does the person collecting data know which treatment arm they're collecting data for? Do the people who are analyzing the data know which section of data they're analyzing? So bias can creep in all along those different paths, okay? So if there's blinding, you need to look at who is blinded and why. Are the populations roughly equal? It's not fair to do a randomized trial of X versus Y if you've got 4 people in one arm and 400 in the other, okay? So you need to have roughly equal sized populations if you can. And do the populations have similar characteristics? There's no point stating that drug X cures heart failure versus drug Y if one half of your patients have heart failure and the other have very severe heart failure and one group don't. Okay, you have to have fairly even characteristics of those patients. Otherwise, you can't really fairly compare them at all. Other thing to look at in methods is follow-up. So lots of people will say, here is a study that shows this treatment is better than the other, And at 1 year follow-up, everything's fine. Now, there's lots of drugs out there now that actually we only use because we think right now that they are the best drugs on the market. There are drugs that have been used in the past that actually in the first year, they have great outcomes, and 20 years down the line, patients who take them have far higher mortality rates than other people, and we've stopped using them. So therefore, the longer your follow-up, the better, because actually it's good for looking at longer term complications or longer term benefits of treatments. However, it is expensive, and follow-up is often compromised in retrospective studies because there's issues with data recording and people forgetting people are in certain studies and they don't write things down, and you end up with bias because you lose some patients will not have records kept that others will. Okay, so look at follow-up very closely. Sometimes people will say these patients are only followed up to a year and this other cohort of patients were followed up to 2 years. They should explain why. If there's a disparity in follow-up, they should tell you why. So for example, if you've got a drug that you give to someone and you say, we'll follow up for 2 years, and actually they only come for a year, it's okay to say they only came for follow-up for a year. But if the reason they only came for a year is because the drug didn't do anything for them and they had loads of side effects, stopped taking it and didn't bother to come to clinic, that's a significant event that you want to know about when you decide whether or not you're going to use that drug. So look at the follow-up carefully, okay? So all of that will make up, you will be able to make a decision on how robust the methodology is, okay? And then analysis. So this is particularly down for clinical trials. So you don't need to know huge amounts about analysis. You just need to know which patients they analyzed, really. So there are 2 ways you can analyze clinical trial data kind of broadly. One is an intention to treat analysis, whereby once you've been randomized to a group, to, I don't know, treatment A or treatment B, doesn't matter what happens to you, you are included in that treatment arm. So you could be randomized in clinic, walk out the door and drop dead of COVID there and then, you would still count as a mortality within that treatment arm. So therefore, you are included in the analysis regardless of what happens to you. You can also have a per protocol analysis, whereby you only analyze patients who actually receive the treatment or intervention or whatever and get to the end of the study. Now, you might say, well, that's quite good because actually then we have complete data on patients who've been through the whole pathway and have been correctly kind of studied. Well, yes, but actually it only gives you an idea of the treatment effect for those people. So let's say you've got patients with asthma who are trialing a new drug, and half of them drop dead because they get hit by buses, and you only analyze those patients who are young and fit. You only, as a per protocol analysis, then you actually end up only knowing how good that drug is for that particular cohort of patients, and you don't have an idea of how it relates to the greater population. Okay, so per protocol analysis, i.e. only analysing those patients who receive intervention or treatment and get to the end, it may overestimate the treatment effect. It may unfairly promote a treatment effect. So an intention to treat analysis is the best way to analyse a trial. So once you've been randomised, it doesn't matter what happens, you should be analysed within that data set, okay? And then the rest of your results. So this might sound very silly, but if you're reading an abstract and you read the results section and you think, I've got absolutely zero idea what is going on here, that's probably not you. That is probably how they've written the results or how the results have turned out. So just because you don't necessarily understand them, don't panic and think, oh, it's because I'm useless. It may be because their results are rubbish, okay? So do you understand the results? Have they clearly laid out what the primary and secondary outcomes are? Often, if you've got a clinical trial, if they've not met the primary outcome, so if they haven't found anything statistically significant when looking at their primary outcome, they may well report hundreds of secondary outcomes because clinical trials are expensive, they cost lots of time and manpower, and patients go through lots of follow-up. It's a nightmare. So you might find that people who don't have the outcome they want in their primary outcome have loads of secondary outcomes where they sub-analyze data and sub-analyze groups to try and find an effect somewhere. And the more you do that, the more you increase the risk of a type 1 statistical error, i.e. you find something there just by chance, okay? So if they have lots of secondary outcomes, beware of the results that they actually have, okay? And then you want to know, have they had a type 1 statistical error? Okay, so what are the p-values? What's the chance that their results are due to chance, okay? Or have they had a type 2 statistical error? So have they accepted a false null hypothesis? Okay, so have they actually not found something when they should have found something, okay? So this often happens in clinical trials where you don't have sufficient power. Okay, so the power of when you power a trial, you do a power calculation that allows you to gather a sample size that if a difference is there, or if there's something to see or something to find, you will find it with that number of patients. Okay, that's the principle. So a power calculation allows you to find out how many people you need to recruit to a trial or have in each arm to find a difference in intervention or treatment if it's going to be there, okay? If you don't have enough people in your trial, you will not have sufficient power and you are far more likely to have a type 2 statistical error where you don't find anything and you accept a false null hypothesis, okay? Therefore, you need to know the definition of type 1 and type 2 statistical errors, okay? You need to know what a power calculation is. A type 2 statistical error is sometimes referred to as beta, and beta, so 1 minus beta gives you your power calculation, okay? So have a little bit of a read around it. You don't need to know loads about it, but it's just worth being aware, okay? Okay. Now then, so that's roughly what I wanted to talk about when you're going through and breaking down and critically appraising an abstract. Now, the other thing to be aware of is this. I'm sure you've all seen this horrendous box, all right? I hate it and regularly forget it, okay? It's worth learning. There's lots of things you have at med school where you learn just for your exams and they go again. For me, it was always the hepatitis serologies. I'd learn it the day before and then completely forget it again. This is something very similar, okay? So you need to be able to make this box and draw it out on a piece of paper for yourself, okay? So, and then you need to know how to look at sensitivity, specificity, positive and negative predictive values, okay? So those are the 4 things that you definitely need to be able to do, because someone could give you an abstract and say, okay, from this, could you calculate the sensitivity or the positive predictive value of this investigation? If you get to the point where they ask you to do that, you'll be doing very well, okay? But just, you need to know how to do it. So things you must know. So sensitivity of a test. These are definitions you have to know, okay? So the sensitivity of a test is the ability of a test to correctly identify patients with a disease, okay? So everyone in a population with that disease will be picked up with that test. Now within that, it's going to probably pick up more people than you need. So sensitive tests tend to have higher rates of false positives as well. But that doesn't matter. You need to be able to pick up all of the people who have disease. The specificity of a test is the ability of a test to correctly rule out patients. So to correctly identify patients who do not have that disease, okay? So the way I remember it is snout and spin, okay? So sensitivity out. So it's a way to correctly rule out patients, and then specificity is in. So how good if at the end of it, you'll be able to rule patients in with your test, okay? So learn these definitions of sensitivity and specificity. You must know those and how to calculate them. And then positive predictive and negative predictive value, okay? So the proportion of patients with a positive result who genuinely have that disease, that's the positive predictive value. And the proportion of patients, the negative result who are genuinely negative, that's your negative predictive value, okay? So things to think about when they give you a critical appraisal, they might say to you, there's a new investigation on the market and it's got a high positive predictive value, okay? Why is that? What does that actually mean? And it's important for you because actually it means it's a good test, because if you have a high positive predictive value, if you have that test and you have a disease, then you don't need to do any more testing. they've got that disease, and therefore you don't have to put your patients through unnecessary and invasive further testing. So high positive predictive value, a very good thing, okay? So that's you guys going through your results and your methodology. Now the discussion, okay, so the discussion is where the author has written down what they think the trial suggests or the treatment suggests, okay? So they've drawn their own conclusions about the data. And you can say that, you can say the authors draw conclusions X, Y, and Z. But having been through the study, you might be able to say, but actually, because of Y, I don't agree with this conclusion, or because of this bit of bias, I don't agree with this conclusion. So your job is to look for limitations throughout the studies, okay, and to be able to look at the author's conclusions and decide whether or not you think they're right. A good discussion of a paper will also have the limitations, not always in the abstract, but in a paper, if you're critically appraising a paper, every paper should have the limitations of the study, and they should also write what they think the future research direction for that study is, okay? So good research projects won't always just answer a question, they'll then look at the next question you need to answer afterwards. And if you are being smart and you've read you critically appraised an abstract and you found some limitations, you can give the limitations of that study, and then you could say, looking kind of moving forward, the authors haven't mentioned, but what they could do is look at X, Y, or Z, okay? Don't get too hung up about deciding what the next cure for hepatocellular carcinoma is. Just have a think, have the author set a future direction? If not, have I got something sensible to say, yes or no? And then based on all of that, so you PICO, you've gone through the introduction and thought, is it relevant to me? Have they done a nice review, and have they set out their work in the context of what's already out there? You've looked at the internal validity, how good's the methodology, how well have they kind of analysed the data, have they used the right statistics, am I happy with the bias, with the randomization, with all these things? You've looked at the results, have you understood them, have you not understood them, do they make sense, what's their p-values, what are the chances of a type 1 statistical error, have they powered their trial correctly, do they have a type 2 statistical error? Then you've looked at the author's conclusions and made your own agreements or disagreements, looked at limitations and future research direction. And then the final and most important question is, would I use this with my patients? How does this actually directly affect me and the patients that I'm looking after? What is the external validity of this study? Okay, so that's the key question at the end of all of this. So I always summarize by saying the study has good internal validity for these reasons, or it actually has poor internal validity for these reasons. And then I say, in terms of external validity and extrapolation to my patient group, I think X, Y, Z, okay? And then this is where it's also really important to think about the difference between statistically significant results and clinically significant results. You might find that patients who have Whipple's resections for pancreatic cancer live longer if they wear blue socks, okay? Just, you might find that. Someone may have done some random trial somewhere, and there might be a statistically significant difference with a p-value of less than 0.0001, that patients who wear blue socks live longer after Whipple's. Excuse me. That's statistically significant, but that realistically makes zero difference to patient care, okay? There's no clinical significance to that. You'll sometimes find that studies will have lots of p-values and they'll fling out all these statistically significant things, but actually there's no clinical significance whatsoever. It might say, I don't know, patients who had severe cholecystitis tended to be 3 foot taller than the guys who didn't. Well, it doesn't make any significance to the patients who were shorter. So it's not a clinically significant outcome, okay? It doesn't make any clinical significance. So always think about that. Just because the p-values are great, does it actually have any clinical significance? So key points, PICO, look for the internal validity and the external validity, understand what a p-value is, know the definitions of type 1 and 2 statistical errors and be able to explain them to someone. You need to be able to understand how to calculate and explain the sensitivity and the specificity stuff. And you just need to practice. You need to literally just sit down and type into PubMed, randomized control trial, and see what comes up. And you need to just practice tearing them apart. Okay, just going through with your system and picking holes in all the different bits and pieces we've talked about. That being said, some studies are very, very good. Some trials are very well thought out. The methodologies are very robust. And if you're sitting in your interview thinking, this is a really good trial. I actually don't have that much to say negatively about it. That's okay. You can always point out the good bits and then the bad bits. Okay, so you can say this is good and it does have good validity because of X, Y, Z or whatever. They won't always give you something to tear apart. Okay. So that brings me to the end of my slides. So what I'm going to do is stop sharing and I'm going to ask everyone to whack on their cameras, and there are going to be some questions, I think.
So we got some in the chat. I'm not sure
Yeah,
if anyone's messaged you directly.
I've got 10 different messages
So
from everyone.
yeah, so the first question is Pico just one line usually?
Yes, it is. Yeah. So I tend to just give one line. So you'll have, let me have a think. So there's a trial called the chocolate trial. It's called the chocolate study, which is worth actually critically appraising because it's a bit rubbish. It's a good example. They've used it in interviews before. It's called the chocolate study. It's by a Dutch group looking at the use of laparoscopic cholecystectomy using percutaneous cholecystostomy versus laparoscopic cholecystectomy for management of patients with acute severe cholecystitis. And the PICO for that is literally a one-liner. You're looking at patients with acute severe cholecystitis. The intervention was percutaneous cholecystostomy versus the comparison gold standard of laparoscopic cholecystectomy. And the outcomes were mortality, and I think they were also cardiorespiratory complications and readmission rate. One line, job done. And it's just, it allows your interviewer to see that you can understand and assimilate information and give a nice clear summary at the end. So I would always just stick it to one line. So
Okay,
that was, yeah, go on, no, go for it.
Next question, would you know the impact factor of the journal, whether the researchers are good in their field in an AFP interview? So would you get the details about that in the interview?
That's a very good question. So they're likely to give you the journal, but not necessarily the authors. So if you don't know the authors, that's absolutely fine, but you can voice that and you'd say, I'd like to know more about the authors. I want to know, are they kind of experts in the field or are they just starting out in this field? Okay. The journals you guys would know. Okay. So like some of them, so I would look at the impact factors. Okay. It was actually worth having a look at the impact factors for the Lancet, for the New England Journal of Medicine, for the BMJ, so BMJ Open, and for Annals of Surgery. Okay. I would have a look at those four. And so I got asked in my ACF interview, I started trying to be clever and talk about impact factors. And someone said to me, right, tell me what's the impact factor of the Lancet. And I'd happened to have looked it up the day before. Okay, so there's a lot to be said for looking things up the day before. But it's good to understand what the kind of, for those big journals that are out there, New England Journal, BMJ, Lancet, what are the impact factors? Does anyone know what an impact factor is? Someone, if you know, someone unmute and just shout out for us.
If you want to put your name in the chat or just say you want to unmute yourself, I'll unmute you because I've put that setting that no one can unmute themselves.
Oh, fine. Okay, ignore that.
Sorry.
So basically, no, it's fine. So basically, guys should know this as well. So an impact factor is the number of citations of articles in that journal divided by the number of submissions over 2 years. Okay, by the number of articles published over 2 years. So it's how many articles have been published, basically, and how many articles have actually been cited. So some journals could publish thousands of articles and no one ever reads them, whereas the Lancet, pre-COVID, did not publish very much, but everyone read it, okay? So it's worth having a good understanding of that. I hope that answers your question.
Hopefully. So the next question, it's similar, and I think you answered it. How would you know if authors are good or experts in their field in the AFP interview?
Yeah, so if you don't know, that's okay. But you just say, and you'd have no idea, but you may say like, I would like to know, I'd like to have, or kind of, I'd want to know more about the authors.
Yeah. Next one is, do you normally get time before to analyze the paper before the AFP interview?
Yes, I believe you get given 5 or 10 minutes depending where you go. In Manchester, for the data section, they give you 5 minutes with the data to sit outside, and you read through the graph, and they give you a pen and paper, and you can kind of go through and make your own conclusions, and then come in, and they'll ask you some kind of basic questions on it. Yeah, so you will have time beforehand, or what they'll do is they'll give you the abstract in there and say, right, you've got 2 minutes just to sit and read through this. But so you'll always have some protected time to read through the article.
Okay, the next question is, the examples you used to made it obvious that it's not clinically significant. When it's less clear cut, do you have any advice on how to assess a study's clinical significance?
That's a very good question. That's a very good question. Yes and no. So sometimes you wouldn't know, and you'd say, actually, I'd like to talk to someone else about this and work out whether or not these are significant for the patients. Sometimes you can have a look at the outcomes. So if the outcomes they're looking at are things like mortality and morbidity or complication rates, and they're significant differences, they are clinically significant. So anything that looks at loss of life, anything that looks at kind of hospital stays, costs of hospital things, side effect profiles, complications, they're all clinically significant because they all directly impact patients. So things outside of that, so random comments about all these patients happens to be there were more males than females who didn't like cheese. So silly things like that. I know that's another obvious, it's another obvious example, but you'll know in the when you read your article what is significant and what isn't significant. They're not expecting you to be kind of clinical experts on any of this. So just a bit of common sense, yeah, morbidity, mortality, kind of complications, hospital stays, costs to patients or costs to healthcare, like things, those are usually quite clinically significant. So just use a kind of bit of like common sense and judgment.
Cool. So the next question is, what are the threats to external validity? How is this different to those factors affecting internal validity? I think that's two different questions.
Hold on a sec, where are you? I've got some other questions. So I've got...
that one was sent to me privately.
Go on, give me that one again.
What are the threats to external validity? How is this different to those factors affecting internal validity?
Good question. So your external validity, so how relevant is something to your patient population? There's lots of things that affect it. And you can break it down quite simply by things like geographical location, local expertise, and kind of patient cohort and demographics. That's the kind of way I think about it. So if you have a study that's done in America, in a center with a lot of money doing ridiculous robotic kidney transplant stuff, that is absolutely fantastic. But if you don't live in a population where patients can afford a robotic kidney transplant, it makes no difference. So it's not really useful for your patient population because you don't even have that service to offer, despite it being very good. Same way as if you... There was an interesting study that was published. It looked at... it was a study looking at a particular antihypertensive. This is a while back now, an antihypertensive that was published in the American Journal of Black Cardiologists. And when you read into the study, it basically said this new antihypertensive is absolutely fantastic. And it turned out that they'd only used one drug, and their study population was a very particular patient ethnicity. And as a result, you could not extrapolate the results to any other kind of patient demographic because of the significant bias they'd introduced. So externally, it wasn't really very useful for the majority of people across the world. It didn't make any difference. So external validity, yeah, geographically, so does my patient demographic fit that of somewhere else? Can I kind of afford those treatments? Is it extremely expensive and therefore I am living in a district general hospital and I can't do that? And what are your patients like? So for example, if you've got a young, healthy, kind of fit population and you're a GP and you live around them, you may not necessarily care much about the changes, minute changes that a new COPD drug kind of causes, because actually you don't have many patients in your population with COPD. So it's little things like that. So those are worth having a look up, kind of factors that will affect external validity. But yeah, so geographic, patient demographic, and then yeah, kind of financial and things like that.
Great. So we have two questions which are quite similar or pretty much the same. Are we highly likely to get randomized controlled trials? Could we get cohort or case control, etc.?
That's a good question, and the honest answer is they could give you anything. Okay, the majority of places will give you a randomized trial because it's easier for them to go through, and they will be looking for they'll have kind of like a mark scheme of what they expect you to kind of say, or most places will. So yeah, randomized controlled trials are easier for your interviewers, but they could give you a cohort or case control. So I practice a bit of everything. Okay, the classic questions that you'll get for things like randomized controlled trials is they'll talk about different types of randomization, different types of bias. They might talk about blinding, the cohort studies and the case controls and stuff. They'll ask you about differences between prospective and retrospective studies and the advantages and disadvantages of both. So just kind of have 3 to 5 advantages and disadvantages of each to kind of go through. But yeah, they could give you anything. So it's best to practice with a bit of everything. If you know anyone who's been interviewed or has a job where you are applying and you know that they do or don't, they have or haven't used a trial in the past, they have or haven't used a case or cohort study, that might be helpful. But otherwise, I just prep everything.
Okay, cool. The next question is, do you know what the interview process is like in Cambridge, and do they read your white space questions, and how does it compare with Oxford?
So I don't know everything about Oxbridge, I'm afraid. I only reluctantly came back down south for the ACF. I didn't apply for either when I did my AFP. So the honest answer is I don't know. All I know about Cambridge is so everywhere will read your white space questions. Everywhere will. You need to put a lot of work and effort into the white space questions because those are your ticket to your interview. They're absolutely essential. Okay, you cannot mess about with them. They're very important. So don't leave them to the last minute and get as many people as possible to look at them. Cambridge they don't have like a minimum cutoff score. So they won't say, oh, you need to get X to get an interview or everyone above this percentage. They will read your white space questions. They'll rank you all and decide who gets interviews and who doesn't. So that's all I really know about them. I don't know that much about the Cambridge AFP, if I'm honest. And I have honestly got no idea about Oxford.
Okay, great. I'll let the person know they messaged on Facebook.
Oh,
Are they more likely to give bad studies in the interview so we can fill up the time?
not necessarily, because you can say just as much about a well-constructed study as you can a poorly conducted study. And that's why I said don't be afraid. If you're reading it thinking, actually, they've done quite a good job here, it's okay to say that you think they've done a good job, and these are the reasons why you think they've done a good job. So don't be afraid to do that as well.
Okay, so when mentioning clinically significant results, should this be defined by the researchers prior to conducting this research, or is this our opinion?
That's a very good question. So if you're being very smart, then in your interview you can say, I would have liked this person to kind of decide what their clinically significant outcomes are. But I think you basically say you have to kind of interpret it on your own. There's a huge push, particularly from NIHR, towards kind of patient and public involvement in research. And actually, it's really essential because you can do all these research studies, and if it makes no real difference to what your patients want, there's absolutely no point. Again, evidence-based medicine, your patients must have a say in what you're doing, okay? So actually, it's quite important to talk to those patients. So you could say to them, I can see no evidence here of any discussions about clinical significance, and actually I'd like to, I don't know, maybe have had the authors use a patient-public interaction group to sit down and decide what the outcomes or what the best outcomes should be, for example. So yeah, any trial that has any evidence of patient and public involvement in designing the trial, top marks.
Cool, so the next question, will they ask follow-up questions after you presented the paper?
They usually do, or they'll ask as you go along. So they might say like, I don't know, tell us about this abstract, and you can do everything you've done. And they might stop you so you can say, oh, I don't know, the trial's been adequately powered, and they might say, well, what is power? Like, what is a times 2 statistical error? But they will usually let you go for a bit and then stop you, and then they'll ask you questions after that, which are basically on what we've talked about today.
Cool. Are there any other resources, either online or books, that you would suggest to improve critical appraisal skills?
There are papers out in this. If you look up kind of just literally a simple Google of how to critically appraise a paper and then PubMed, there's people have written kind of formal guides on PubMed that are actually very good. Some go into a huge amount of depth that you just don't need to. that's why I've kind of I'm a very simple man. That's why I've broken it down by PICO and all the kind of stuff going through it. But there are guides out there from researchers for researchers. There's lots and lots of different YouTube channels and stuff. I didn't know of any books. I didn't use any particular books to go over it, but I'm sure there are books out there. I would be careful about being scammed into buying lots of books. People have written books on how to get an AFP and how to do all this sort of stuff, and I kind of disagree with it a little bit. You don't need to buy all that sort of stuff. It's all out there on Google for you.
Cool. Do we need to know the advantages and disadvantages of different studies?
Yes. Yes, you need to advantage. Yeah, sorry. Yes, you need to know the advantages of prospective versus retrospective, of randomized versus non-randomized. They're quite important, and it's important because you can't always do a prospective study and you can't always do a randomized controlled trial. So it's important to know the benefits of them and when you would use them if you possibly could.
Cool. So I've got one more question on my list. I have seen tips that contacting researchers at the academic unit you are applying for. Would you recommend this, and in what scenario would this be beneficial?
Yes and no. So when I came to Manchester, I wanted to do head and neck. I wanted to do like resectional head and neck oncology and maxillofacial. And I'd spoken to the guy who runs the head and neck unit up in Manchester, and we discussed a few projects. And he basically said, I do a lot of thyroid cancer. Come on, we can do some projects on thyroid cancer. And that was roughly it. And it's good at interview. If someone says to you, oh, why do you want to come to Manchester, for example? And you can basically say like, oh, I'm interested in, because the reason you're coming is the reason you're applying for an academic place at that place is probably because you have a research interest up there, or there's something going on. But you need to be able to say that you're aware of the research that's going on. So if you can say, I've spoken to Prof XYZ and we've discussed a project in this, it just shows you've gone the extra mile and you've put in the effort. They're not expecting you to give them a complete PhD thesis and definitely do that project. I changed my mind from head and neck very early on and didn't do anything to do with head and neck in the end. So it doesn't actually matter that much. But it's good because it shows the initiative. It shows that you've cared enough to get in touch with people and actually look into what's going on in that unit. And that goes a long way. So I think it's important. Sometimes people won't reply to emails, so I'd email them earlier rather than later. And it's not necessarily about what research project specifically you're going to do. It's just saying, hi, this is who I am. I'm interested in your research. Would it be possible to have a kind of chat about potential projects? I'm going to be applying for the interview, and see what they say when they come back. I hope that helps.
Can I nab the name of your head and neck doctor?
Yeah, he's a guy called Jared Homer. He's very. The other guy is Navin Mani. Navin Mani is a wonderful man who's basically blurs the line between Max Fax and head and neck, and he's incredibly enthusiastic and has lots of projects. He's a really nice guy, so I would highly recommend anyone interested in ENT, Navin Mani and Emma Stapleton. Emma Stapleton is a phenomenal skull-based surgeon at MRI, and she's incredibly supportive. So anyone interested in ENT or neurosurge stuff, they're the people to get in touch with.
I recommend Mr. Manny as well. One more question. Could we please have your email address, if possible, in case we have more questions to ask?
Yes, you can. I will reply with my email address. The caveat to that is that I am incredibly busy, guys, and I will not be able to look through people's white space questions. I promised I would, but I've got about 4 or 5 friends I'm already doing it for, and I've got the ACF ones to do. So I'm afraid I'm not going to be able to go through everyone's kind of personal white space questions. But if you've got other generic questions, I'm happy to have a look. The other resource I would recommend, I'm just writing on here, is Project Cutting Edge. I know I sent it privately to someone. I'm really sorry. I don't know how I can do this. I have
your email address, so I can let everyone know what it is. Is it the same as the one I've been emailing before?
Yes. And then, Project Cutting Edge is a platform that myself and 3 friends made that is intended to teach people or to demystify the process of getting into core surgical training. But as part of that, As part of that, we wrote a whole load of articles on the AFP and kind of how to approach getting into the AFP and getting an AFP. And most of what I have said is there. Most of what I would have to say about the white space questions and getting an interview and answering interviews and things is on there as well. So have a look at the AFP pages on Project Cutting Edge. It's not just for surgery, it's very generic. It's for anyone applying for AFP. Does anyone have any more questions?
No, I don't have any myself. Did anyone message you privately?
Let me have a look. I think there were a couple of questions about me doing another session that puts into practice and uses more examples of things I've gone through. I know that would be very helpful, but I'm afraid, I'm really sorry, I just do not have the time at the moment to do that. What I would suggest is if you go on YouTube and type in critical appraisal of abstracts, there are hundreds of videos of people doing it and taking you through randomized controlled trials and other studies, and they are brilliant, brilliant examples. There's a guy he's an American, I think he's a professor of epidemiology, who's an interesting character, and he's unbelievably passionate about critically appraising abstracts, but he's very, very good. And it gives you, again, the system to go through, and it just goes over and over and over abstracts and critically appraises. So you'll be able to get a flavour of what you actually need to do. So I would highly recommend you have a look on YouTube. There's lots of examples.
Okay, so I've put your email address into the chat and Project Cutting Edge. So I've also put in a feedback form into the chat to kind of like bribe you all certificates, but feedback is very important for our society and Dr. Spires. And we have another statistics lecture coming up next week on Monday evening, and I've linked that too. So if we're all done, everyone needs to nab those links before I end the meeting for everyone. But
So
thanks, Harry.
That's fine. Final couple of points is that no one, when you start an academic foundation program, they don't expect you to be a fully fledged early career researcher with funding and an idea of what you want to do with the rest of your life. They don't expect you to do that. They expect you to be able to become that. So they want people who will work hard, who have a passion for academia and understand the pathway and have a trajectory that will allow them to step into the early career researcher role. That's all they want. So don't go in there thinking, oh, haven't got hundreds of papers and I haven't done all of this. I hadn't done any of that, and I still haven't done any of that. And actually, the more you go through, you realize it's not about quantity, it is very much about quality of your work. So you don't have to go in being a fully formed article. You just need to go in being able to get on with others, work well in teams, and have a passion and enthusiasm and the skill set to become a researcher that they will mold you into in the future. So no one needs to have any imposter syndrome. Practice as much as you can. Get your white space questions read by as many people as possible. Go through about 5, 6, 7, or 8 drafts, okay? Make sure for your white space questions that you read the question. Everyone who has sent me white space questions so far has just told me how great their presentations and publications are. And that's not what people want to know. You need to answer the question. So write your answer, read the question again, and see if you've actually answered the question. Okay. If someone says to you, tell us about some research you've done, they don't want to know that you've presented it at 400 different conferences. What they want to really know is what skills you've learned and the teamwork you've used and the organizational skills you've got. If you want to mention it's been published somewhere, fantastic. You can use that as a tiny one-liner just to say, like, just to prove you've taken the research from idea through to delivery. But it's not about whether or not you've published. It's about the skill set you've learned, okay? Same with your answers in your interviews. It's not about being a world accomplished, whatever. They don't care what you've done in terms of research output necessarily. They want to know about skills that you will have learned and your ability to adapt and overcome things with research. So get your white space questions done. And when you're practicing, practice with other people, okay? The other way to do it is I filmed myself answering the kind of questions, and it's the single worst experience of my life, okay? But if you can watch back the video of you answering the question, like the interview questions, and you don't cringe at your own performance, and you're not stuttering, and you've got out all the points that you want to get across in about 2 minutes, you're on track, okay? So just practice as much as you can and make sure you film yourselves and practice other people, all right? Now I will stop waffling on because we've all got things to do this evening.
Thank you very much, Harry. Really good to have you do our events again. We're really grateful. We know how busy you are, and there's a lot of thank yous to you as well. No more chance for questions. Sorry, guys, and everyone can pop off now. I'll end the meeting. Make sure you fill out the feedback form. Thanks.
Good
Bye.
luck, guys. Bye.